Diabetes insipidus is a disease where there's inability to produce concentrated urine as a result of ADH dysfunction. This could be due to a deficiency or insensitivity of ADH. ADH stands for anti-diuretic hormone and it is also known as vasopressin. ADH is synthesized in the hypothalamus, more specifically in the supraoptic and paraventricular nuclei. After its production, ADH is transported along the nerve fibers to the posterior pituitary, where it is stored until it is released into the bloodstream. The primary function of ADH is to regulate water balance in the body by influencing the reabsorption of water in the kidneys. There are three major receptors for vasopressin in the body. We call them V1A, V1B, and V2. V1A receptors are found in the vascular smooth muscle cells, and activation of V1A receptors will induce vasoconstriction. V1B receptors are located in the anterior pituitary and throughout the brain. This mediates the effects of ADH on the pituitary, leading to adrenocorticotropic hormone release, that is your ACTH. V2 receptors are in the principal cells of kidney in the distal convoluted tubule and collecting ducts. They mediate the ADH response. ADH acts on the V2 receptors located in the basolateral surface of the principal cells, and this leads to a lot of reactions, and finally unique water channels called aquaporins will be moved and is inserted into the luminal membrane. The water channels will span the luminal membrane and permit water movement into the cells down an osmotic gradient. This water is then rapidly returned to the systemic circulation across the basolateral membrane, allowing more water to be reabsorbed back into the bloodstream instead of being excreted in the urine. So as a result, urine volume will decrease and the urine becomes more concentrated. ADH also plays a crucial role in osmoregulation, which is the maintenance of body's internal environment in terms of solute concentration and water balance. When the blood osmolality is high, that means there's a high concentration of solutes in the blood. The hypothalamus senses this change and stimulates the release of ADH. ADH will then go and act on the kidneys to conserve water and reduce urine output, helping to maintain the body's water balance. In addition to its role in water balance, ADH also has vasoconstrictive effects on blood vessels. This means it can cause blood vessels to constrict, leading to an increase in blood pressure. This effect is more prominent at high concentrations of ADH. It's also involved in stimulating thirst. When blood osmolality is high, ADH is released and it signals the brain to induce sensation of thirst, prompting an individual to drink more fluids to help restore their water balance. So what are the stimuli affecting the vasopressin or ADH secretion? So the factors that would increase the vasopressin secretion are increased effective osmotic pressure in the plasma, decreased extracellular fluid volume, pain, emotion, stressful situations or exercise, nausea and vomiting, drugs like clofenac and carbamazepine, and angiotensin 2. The factors that would decrease the vasopressin or ADH secretion are decreased effective osmotic pressure of plasma, increased extracellular fluid volume, and alcohol. So that's all about ADH. So what happens in diabetes insipidus? In diabetes insipidus, there's an inability to produce concentrated urine as a result of ADH dysfunction. There are two subtypes, that is central diabetes insipidus and nephrogenic diabetes insipidus. In central diabetes insipidus, the problem is in the posterior pituitary. The posterior pituitary will fail to secrete ADH, so they cause an ADH deficiency. In nephrogenic diabetes insipidus, the kidneys fail to respond to the circulating ADH, so they have an ADH resistance. The causes of central diabetes insipidus can be familial, Did-Mode or Wolfram syndrome. This is where you have diabetes insipidus, diabetes mellitus, optic atrophy and deafness. It could be due to infections like tuberculosis, meningitis or cerebral abscess, tumors like craniopharyngioma or a hypothalamic tumor, vascular causes like ischemia in Sheehan syndrome, and aneurysms or hemorrhage, infiltrative causes like sarcoidosis and Langerhans cells histiocytosis. It could also be due to traumatic brain injury or surgery. Nephrogenic diabetes insipidus could be caused by familial cause like vasopressin or aquaporin 2 gene defect, renal diseases like renal tubular acidosis, electrolyte imbalances like hypokalemia and hypercalcemia, drugs like lithium and demiclocycline, and sickle cell disease. So how do these patients present? These patients will present with polydipsia, polyuria, and persistent thirst with dilute urine. Most cases are normonatremic. If the access to water is limited, like in elderly patients, they can present with dehydration and severe hypernatremia, leading to altered mental status, lethargy, seizures, and coma. So how do we diagnose these patients? These patients will have high plasma osmolality with low urine osmolality, high or normal serum sodium, high 24-hour urine volume. To identify the cause of polydipsia and polyuria, we can do the water deprivation test. In psychogenic polydipsia or normal renal physiology, restricting water will lead to more concentrated urine. However, in nephrogenic or central diabetes insipidus, the patients will excrete a high volume of inappropriately diluted urine. To differentiate between cranial diabetes insipidus or nephrogenic diabetes insipidus, we can do the desmopressin acetate replacement test, which is also known as DDAVP test. DDAVP is a synthetic analog of ADH. So, in central diabetes insipidus, they don't have ADH. So, when you replace the ADH with DDAVP, they can concentrate urine. So, they have reduced urine output and increased urine osmolality. In nephrogenic diabetes insipidus, they are insensitive to ADH. So, even if they have the DDAVP as an analog, they won't concentrate the urine. So, no effect is seen in urine output or urine osmolality. We can also check the blood glucose to exclude diabetes mellitus, which is a differential diagnosis in patients presenting with polyuria and polydipsia. MRI can also show a pituitary or hypothalamic mass when it comes to central diabetes insipidus. When it comes to management of diabetes insipidus, treat the underlying cause. In central diabetes insipidus, DDAVP can be administered intravenously, intranasally, or orally. For nephrogenic diabetes insipidus, first-line treatment consists of salt restriction and water intake. Thiazide diuretics can also used to promote mild volume depletion and to stimulate water reabsorption.